May I request Dr. I.P.S. Oberoi to come on stage for the panel discussion, and I request Dr. Wakankar also to please come on stage, please.
Sir, apni.
If there are any
incidence of doing reverse shoulder, you said told 65%. When it was initial, say about 5 years back, the survival was found to be in young patients, maybe 7, 8 to 10 years. Now what you are doing since past 10 years, what is the survival now? What do you expect? Though the ultimate we know what you showed was if it is failed one, you might land up into an arthritis. This is something which has been explained before taking on the surgery. But what is the survival now, what you had?
No, I think implant designs have modified, and as we talked about Gramot stage 2 and as well as the lateralized designs with augmented glenoids, the survival is becoming better. Right now, whatever the literature says, that survival is around 15 years to 18 years or so. We still have to await how things are going to happen in the future. So that is why the point raised by Mukesh as well. We have started seeing a lot of younger patients, 35, 40, being implanted a reverse shoulder. I think that's an area where probably we are still afraid to venture into.
So, as in Mukesh's talk, there were certain modifications. You're using an offset, you're using a little, putting the glenosphere distally. Is it available with every company? And second thing to Maheshwar sir, the combined version as in hip, does it matter in reverse shoulder?
So there are certain companies where the glenosphere can be distalized as well as lateralized. It's not available with all companies. Second question to answer your combined anti-version, anything excess will lead to a problem, but you can't go much beyond like we do in the hip vertical placement and all. So here, individual retroversion. For glenoid, it's hardly any retroversion. Even neutral of 5 degrees is fine. But for humerus, you have to be around 20-degree retroversion only.
So, of course, combined retroversion concept is applicable even here. But it is a different condition in the hip. Hip is an inherently ball and socket, very stable design. This is a ball and socket, but it's not as stable as hip joint is. So though we should be almost quite optimum in terms of combined retroversion, but if you go a little out, it can dislocate. It can have a hinge at the back or in the front and dislocate. So that is a thing that you have to be sure on the table. Normally you can accept 10 degree of retroversion as well as forward version on the glenoid side. And accordingly you should be very, suppose you combine 10 degree of retroversion on the glenoid side with 20 degree of retroversion on the humerus side, you are taking a risk of dislocation. So some amount of that carefulness is required.
I think my question to Dr. Oberoi and Dr. Maheshwari, that what are the indications when to do, you are going to fix it, when to do hemi, and when to do reverse, or when you are going to do conservative? That is the larger question for the house.
So I think whenever there is a head split, I think that's an indication where you actually go in for a hemi. So when you have a 4-part fracture where the head is also split. Number 2, when you have an elderly patient, which is osteoporotic as well, the failures, as rightly pointed out Dr. Maheshwari, the failure of osteosynthesis are very, very high. So these are another subgroup of patient where we're going to do it. So in a 4-part fracture dislocations where the patient is elderly and osteoporotic, primarily we try to do a hemi-arthroplasty. If the head split, again, that's a case where I would do a hemi-arthroplasty.
So let me give my algorithm on this. So we are talking about people beyond 65, 70 years of age, okay? Before that, before 60, you can fix a lot of them, even 4-part, reasonably well because bone is good. Beyond 65, 70, bone quality is drastically poor. 4-part fractures, if you try to fix them, you'll be lucky that it doesn't cut out and everything doesn't happen. Otherwise, so I have 3 treatments for that age group. One is conservative. So if it is reasonable, even if you treat them as it is, they get reasonable motion. So these are low-key patients, non-affording patients who are okay to live with what I call acceptable malunion. They're quite okay, they're happy sometimes. The second category is a youngish patient who is 60, 55, 60, four-part fracture. You can't reconstruct it. You cannot also do a reverse there. So that is a window where hemiarthroplasty has a great role. As soon as that window shifts from 65 to 70 plus, no more hemiarthroplasty, it is reverse shoulder arthroplasty. Another thing that decides between reverse and hemiarthroplasty is the quality of greater tuberosity. If your greater tuberosity is nice and chunky, it will heal up very well, at least to the shaft. If your greater tuberosity is a very thin sliver, whatever you may do, hemiarthroplasty will not work. So these are the few criteria which I use to decide conservative, hemiarthroplasty or a reverse arthroplasty.
Even in young, if it's a head split fracture, I'll suggest osteosynthesis should be done first. Don't jump to reverse. Even if it's a badly shattered head, if you can get something, reverse can be done anytime later in younger patient. But yes, for elderly, you should think about primary reverse.
One more question, Dr. Maheshwari. What are the signs of avascularity of the femoral head in four-part fractures?
Oh, this is a criteria of by Hertel that we normally use. I would say, I'm sorry, this is my own funda. I don't know whether it is correct or not. But if you see X-ray AP lateral, you should do always 2 X-rays minimum, if not CT scan. And if you see 90-degree deflection of the head in 2 planes, in 1 plane it can happen. But if it is in 2 planes, that head in a 4-part fracture is avascular. It's lying in the middle, rotating everywhere. If it is 90 degree in one direction, capsule still may be attached somewhere else. So all 4-part fracture head is avascular, that's not correct. That's my first criteria. Second is, if there is any bone connected to that, the head, surgical neck part of the head, anatomical neck part of the head, if any bone is attached there, which means either a spike lower down, where the capsule is attached, or a part of the GT with that. That means blood supply will come from there. So you should have something with the head which will bring blood supply to the head and it may still survive. If head is free, no bone connection here and there, and it is rotated by 90 degree in 2 direction, that as soon as you open up, you can take it out like this.
Sir,
How good are the results of reverse shoulder in a failed hemiarthroplasty?
Well, good means every revision surgery is not as good, but I think it's a good option. Because in a failed hemiarthroplasty, shoulder is like this, and if it starts going out here and there, it is painful also. And the reverse shoulder gives you a good function, because it can bring back at least forward flexion. Problem is, it cannot give you rotations then, because GT, LT, everything is gone. But still, it is better than having a flailed shoulder.
Sir, my question to Dr. Oberoi and then Dr. Maheshwari also the same question. In a 60-year-old patient with the rheumatoid arthritis, what will be your preference for primary anatomical or the reverse shoulder?
I think in such cases, probably the cuff is also important. And in patients which have got these kind of inflammatory arthropathy, the quality of cuff is poor. And as he rightly pointed out, the quality of the chunk of that tuberosity is also very poor. It's very thin sliver-like. So it is a good idea to actually go in for a reverse to get a better outcome. And these are low demand patients. The longevity of these reverses would last much more longer. So for me, probably a 60-year-old rheumatoid arthritis, 4-part fractures would actually go in for a reverse straight away.
Same opinion, sir?
So there is a bit of a euphoria about reverse shoulder replacement all over the world I see. I don't agree with it. I'm not willing to digest it so easily. They are going away from anatomical replacement, that means total shoulder replacement, even in 65, 70 where cuff is intact. And the reason is, cuff is going to degenerate tomorrow. This total shoulder is going to fail. So anywhere, actually they are doing primary reverse shoulder replacement in osteoarthritis with intact cuff at a particular age. For example, 65, 70. This guy is going to last for 15 years. If you do a total shoulder replacement today, because the cuff is okay, who knows what happens 5 years from now? His cuff will degenerate and that total shoulder will fail. So with that logic, they are doing more and more reverse shoulder replacement for cases where anatomical arthroplasty used to be done earlier. And that's a change, recent change.
Right, sir. Thank you. I think it's the end of the session. Yeah, sir. So we will invite the next session. Chairperson, and thank you all the panelists and all the speakers for a great and wonderful show.
Post-decay A manifestation, how have been prevented? Yeah, sir.
Well, good afternoon. So, from knee to shoulder, and now I will be taking you to the basics. Well, this is a story of a lady who was operated at the age of 59, bilateral knee joint replacement performed, and she basically had rheumatoid arthritis. Now, these are the pre-operative x-rays, and only on the 10th day it was discovered that there is some deviation of the tibial component. Gradually, this kept on increasing, and the patient still was not very symptomatic for 4 years. It was only in 21 that there was some history of injury, and then she was not moving at all because of the pain in the right thigh. This continued, and it was in 15th February 2022 she became bedridden. The X-ray hip did not show any evidence of fracture, and the patient started slowly walking from March 22 with support, but pain persisted. Now, when the patient went to the surgeon for revision of the knee joint, it was examination by the general physician who took another X-ray which earlier had not shown any fracture, and this was the hip fracture. Naturally, this was replaced, and the patient continues to be with the same knee joints with the subsidence there. Now a question arises out of this story. Is osteoporosis common and undertreated prior to total joint arthroplasty? I would say yes. Pre-operative osteoporosis screening is not commonly performed, and a pharmacological osteoporosis treatment is not instituted, and even otherwise, post-operatively also, a surveillance of osteoporosis is not kept on that patient. So, significant proportion of patients with end-stage osteoarthritis, they do have osteoporosis. It is not only rheumatoid arthritis patients or patients with secondary causes like end-stage renal disease or patients on steroids. Friends, Indian Orthopedic Association had a committee for fixing the guidelines, and only last month, after more than 2 years, we have come to conclusions. So I'm just passing through the terminal guidelines when it comes to the drugs. So teriparatide, there are so many guidelines, but I will go for very few ones. Well, do not use teriparatide if parathyroid hormone is above normal. Hypercalcemia, elevated alkaline phosphatase, or the patient has metastatic cancer. Now it is written, when it had gone for Delphi voting, there were how many consensus and what was the round. The other one that I would like to prefer, while all agree that teriparatide is used in the treatment of osteoporosis and also to prevent bone fracture, but off-level use of teriparatide can be effective in non-union, delayed union. Therapy with teriparatide is ideally not recommended after 2 years, but can be considered if the patient remains at or has returned to having a high risk of fracture. So friends, we can still use it after 2 years. Let me switch over to denosumab, and combination therapy of teriparatide and denosumab are advocated in severe and very severe stage of osteoporosis. Following inadequate response to oral anti-resorptive therapy, denosumab may be administered. Additional indications of denosumab, maybe most of us are aware, apart from osteoporosis, include giant cell tumors to reduce vascularity preoperatively and for inoperable GCT relapses, bony metastasis, avascular necrosis of hip. While on treatment with denosumab, if a patient develops a fragility fracture, anabolic teriparatide may be the preferential combination. And one more point about denosumab. Normally, teriparatide is sequenced with denosumab, but in case of a reverse sequence, that is, denosumab followed by teriparatide, this is not good, but this can increase the fracture incidence in earlier months of transition, and hence patient need to be protected by a walking aid. Friends, romosozumab, in the name of Evenity, has been introduced in India, and now it is more than 6 months. I have occasions to prescribe this. 4 points I would like to make clear what we have written in IOA guidelines. Number 1, romosozumab may be safe in both sexes. However, elderly females with severe osteoporosis, T-score more than -3, are the preferred group as per DGCI, Drug Controller General of India. Even in international studies, they have not yet recommended to use in males, but there are international reports, and I have also used in few patients, male patients, and they have done well. Romosozumab has a dual mode of action, that is increased bone formation and reduced resorption, and is currently not recommended to be used for more than 1 year. Romosozumab given once a month at 2 injection sites for 12 months, every month. It is contraindicated in patients with cardiac events in the previous year. This is one point which, by going through the net, patients' attendants are very apprehensive. Here, you have to make it clear if the last year has not seen any cardiac event, it is safe to be given. And romosozumab, fourth, is not to be combined with or followed by teriparatide. It will have to be followed with oral anti-resorptive drugs. Well, you must have been surprised by now that I have not talked about bisphosphonates. Are they really out? No. In our discussions, it was said that it is not the proper drug, but internationally also, nationally also, this is the drug which still is there, and ideal indication for use is primary osteoporosis, including high turnover bone disease with high parathormone and high alkaline phosphatase. Well, everyone knows what is type 1 and type 2, and osteoporosis, all of us are aware, but many of us are not aware that they can be classified into high turnover and low turnover bone disease. Well, I would not like to go through all these regarding bisphosphonates. So in the end, I would like to conclude that preoperative osteoporosis screening is a must. Pharmacological osteoporosis therapy must be given both as preoperative and also have a post-operative surveillance to avoid any future fragility fracture. And Dr. S. Prasad gave me this slide that a patient with this much of osteoporosis manage osteoporosis with newer drugs, and it is better if we delay surgery for 3 to 4 months. Thank you very much.
Thank you, sir. Thank you, I think, for drawing attention to a very important aspect. Can we invite a couple of questions from the audience? If not, then I have just one question. That is, that in this intervening 3 or 4 months, so how would you like to treat this patient?
Well, any patient who has osteoporosis, first you have to investigate. So you go for a DEXA scan, look into what is the level, and it can be classified into mild, moderate, severe, and very severe. More than minus 2.5, and as I have told you, minus 3, if it is minus 3, if the patient can afford it, Evenity or romosozumab is the best drug, but affordability becomes a problem. If you want anabolic effects to be there, you can give anabolic, and not only, you can combine the two, the anabolic with denosumab, and that should see your patient through from -2 to -3.
Thank you very much, sir. Thank you for your
Thank you.
Thank you, sir.
How does that
No,
correlate?
whole body DEXA does not only confine to hip and spine, they also look for femur, whole femur, and also forearm. The bone which has the least one should be taken care of, the minimal one.
As knee surgeons, we are interested in osteoporosis around the knee because my implant should not sink if it is osteoporotic bone. One patient rightly asked me, "Doctor, how are you sure that my bones are ready to take your implant?
Right,
Whether I am osteoporotic or not."
right.
So I tried doing this and there was no company telling me that you can quantify osteoporosis in the knee. You can say in the hip, in the spine. Do you think there is a correlation?
No, so I said you can go for the weakest bone, the radius. And if the radius is -4, I have seen even up to -6. So -2.5 in radius and above, you have to be cautious that yes, knee status may be similar.
Just to answer your question, you can get the quantitative CT scan done. That is also means to quantify the bone osteoporosis, and in that you can get it done for the specific joint. So anybody who is doing CT scan, if you ask them, they'll do the QCT.
Thank you, Jai sir, for enlightening us. Now I request Dr. Sandeep Kapoor sir to give his visionary talk on bridging orthopedic surgery and entrepreneurship for a super specialty dream.
So, good evening everyone. It's probably